Good morning, everyone. Thank you to the Joint Audit and Evaluation Committee for being here, as well as our invited guests. We have a full agenda this morning, but wanted to extend our welcome to all those that are here and all those in the audience for tuning in to this Wednesday, December 13th meeting of the Joint Audit and Evaluation Committee. Let me turn it over to my co-chair, Delegate Solomon, to see if he has any additional opening remarks.
Thank you, Senator Lamb. Just wanted to wish everybody a happy Hanukkah, happy holidays, and we're looking forward to the discussion for today. We'll turn it over. We have a long agenda, so keep it brief. Thank you.
Great. First on the agenda, we have the Maryland Department of Health Medical Care Programs Administration. We're going to begin with the Office of Legislative Audits and Mr. Greg Hook and his audit team. Welcome.
Your mic.
Technical difficulty. Oh, sorry. Okay, sorry. For the record, my name is Greg Hook. I'm the legislative auditor, and accompany me today at the table to present the findings of our November 2nd, 2023 audit report on the Medical Care Programs Administration. Brian Tannen, our Director of the Compliance and Performance Audit Division, Audit Manager Eddie Rubenstein right next to me, and Principal Senior Auditor Rob Smith. Before we get into the findings, I briefly want to explain how OLA audits Medicaid. OLA conducts 4 separate audits of MDH's various components and responsibilities of Medicaid, which we do to ensure that we can obtain sufficient audit coverage and conduct manageably sized audits. As noted on pages 9 and 10 of the audit report, this audit covers MCPA's primary administrative functions, including MCPA's monitoring of its provider payment system security and controls, recipient and provider eligibility, and third-party insurance recoveries. The audit scope also includes certain aspects of Medicaid related to nursing facilities, hospital services, and the Community First and medical daycare programs. From a financial perspective, the amount of fiscal year 2022 Medicaid funding covered by this audit, which is generally evenly split between federal and state funds, was $4.3 billion. The audit report contained 10 findings within 5 functional areas, with 6 repeat non-cybersecurity related audit findings from our prior audit report. Due primarily to the significance and repeat nature of the findings, we determined that MCPA's accountability and compliance rating was unsatisfactory, meaning that OLA will perform a formal follow-up review of MCPA's corrective actions during calendar year 2024. Although we did not attempt to draw a specific correlation between the findings in this report and MCPA's employee vacancies, we did comment that as of June 30th, 2022, the rate stood at slightly more than 14% of the authorized 618 positions. In the audit, we found that MCPA could be improperly paying claims that should have been paid by a third party. In addition, we noted that questionable recipient eligibility was not always comprehensively investigated, and we identified 18,000 claims totaling $3.6 million that were paid on behalf of 5,600 recipients, for which the date of service was after the recipient's date of death. The audit report also included 5 findings, 4 of which were repeats in the program oversight area. Another 2 findings were cybersecurity related and will be discussed in closed session, along with the 5 cybersecurity related findings from the MDH Office of Secretary audit report that was presented at the November JAEC hearing. If you recall, we were faced with a hard stop for that hearing, and it was decided to defer discussion of those findings to this hearing. One final note is that OLA's data analytics unit provided some meaningful input on this audit fieldwork, and later this morning, that unit will present the results of its review of Maryland tolling data, which will provide some insight into the powerful audit tools that OLA possesses. With that, I will turn it over to Eddie and Rob's and Brian's capable hands to present the detailed 8 non-cybersecurity related audit findings.
Good morning, co-chairs and members of the committee. My name is Eddie Rubenstein, and I was the manager for this audit. Eric, if we could start on slide 6, please. I think Greg covered most of the first 5 slides in his introduction.
Okay.
So finding 1 on slide 6 was that MCPA did not ensure that all referrals of potential third-party health insurance information were investigated and recorded in the Medicaid Management Information System, or MMIS. This could result in MCPA improperly paying claims that should have been paid by other entities, such as third-party insurers. MCPA uses a vendor to identify other potentially liable parties and receives referrals from several other sources, including its managed care organizations. These referrals need to be recorded in MMIS so that claims submitted for the recipients will be flagged for review to determine if another party should pay any portion of the claim. Identification of these claims is critical because under state and federal regulations, Medicaid is supposed to be the payer of last resort. Our review disclosed that MCPA did not verify the monthly referrals from its third-party liability vendor were properly recorded in MMIS. Specifically, only 180,000 of the 1.5 million referrals sent between January 2021 and June 2022 were actually recorded in the system. For example, almost 85,000 recipients' information sent in January 2022 was not recorded. Since this information was not recorded in MMIS, claims paid for these recipients were not subject to review to determine whether anyone else should have paid for the claim. Our analysis of claims paid for these recipients during the remainder of the calendar year identified claims totaling $103 million that were paid entirely by MCPA. MCPA also did not track referrals from the MCOs and could not readily determine the number of referrals received or whether they had been investigated and recorded in MMIS. Based on records submitted by the MCOs, we determined that approximately 176,000 referrals were submitted during fiscal year 22. Our test of 135 of these disclosed that 86 had not been investigated and recorded as of November 22. Moving next to slide 7, finding 2 was that MCPA did not have effective processes to identify, prevent, and recover questionable Medicaid payments. MCPA has several processes to identify questionable activity, such as recipients who are deceased, missing Social Security numbers, or who are receiving benefits in another state. These instances are either referred to the Department of Human Services or local health departments, or investigated and resolved in-house by MCPA. In all cases, MCPA is responsible for ensuring proper corrective actions are taken. At the time of our review, MCPA had not referred instances of recipients with missing Social Security numbers to DHS or the local health departments since November 2021. MCPA also could not document its review of those entities' investigations for referrals made prior to that time. MCPA attributed these conditions to the December 21 ransomware security attack. MCPA also did not review DHS and local health department investigations of recipients who received benefits in other states to ensure the proper corrective action, such as recovery of payments, was taken. While MCPA could not readily determine the number of recipients that were identified through this process, based on a report we were able to obtain from MCPA, there were over 11,000 instances during April 22 alone that needed to be investigated. Similar findings about the missing Social Security numbers and recipients receiving benefits in another state were noted in our prior report. In response to that report, MDH advised that it established an automated system to track and document its oversight. However, access to this system was disrupted by the ransomware attack, and at the time of our review, no documentation of these reviews was accessible. We also found that MCPA did not have a process to identify, prevent, and recover fee-for-service payments related to incarcerated recipients. We performed a match between the Department of Public Safety and Correctional Service records and MMIS claims for a 4-year period, which identified $3.5 million paid for almost 2,000 recipients who were incarcerated at the time of service. Under federal and state regulations, Medicaid only covers certain services such as inpatient hospital care while someone is incarcerated. MCPA also could not document its efforts to identify and remove deceased individuals from Medicaid. MCPA has a monthly match process to identify these individuals using state and federal records. However, MCPA could not document that the matches were performed from August 2018 through March 22, and they attributed this again to the ransomware attack. Furthermore, MCPA did not investigate payments where the date of service occurred after the recipient's date of death. We performed a match which identified claims totaling $3.6 million associated with 5,600 recipients, which we believe warrant further investigation to determine if the payment should be recovered. Moving to slide 8, finding 4 was that MCPA had not established adequate oversight to ensure that Medicaid recipients participating in the Community First Choice program receive services in accordance with their plans of service. CFC is a program in which elderly or disabled individuals who would otherwise live in a nursing facility receive services to enable them to continue living in their own homes. These recipients receive assistance with their daily living activities from providers called personal assistance providers, based on an individual plan of service. The local health departments are responsible for evaluating the quality of these services, which they do through periodic nurse monitoring visits with the recipients. We found that MCPA had not established a process to ensure that nurse monitoring visits occurred timely for each recipient. Our analysis of MCPA records determined that as of November 22, almost 1,900 of the 10,000 recipients receiving personal assistance were more than 60 days overdue for a monitoring visit, including 901 individuals who were more than 1 year overdue. We further noted that Baltimore City was responsible for the vast majority of these 901 instances. A similar finding was noted in our prior audit report. Although MCPA advised that it had implemented a process to follow up with the local health departments, we found the process was not effective, and MCPA could not document that it had addressed the issue of untimely monitoring visits with the local health departments. I'm now going to turn it over to Rob, who will discuss the remaining financial related findings.
Good morning, everyone. My name is Robert Smith. I was the senior auditor for the MCPA primary audit. I'm going to begin on slide 9 of our presentation. This finding relates to nursing facilities, which disclosed that MCPA did not monitor its contractor to ensure that reviews of Medicaid recipients receiving services from nursing facilities were performed timely. The purpose of these reviews are to ensure that a recipient continues to require the level of care provided by a nursing facility. The contractor was required to perform these reviews quarterly during the first year a recipient is in a nursing facility and annually thereafter. Our analysis of almost 14,000 recipients who should have received at least one review during calendar year 2021 disclosed that over 2,300 recipients, or 17%, had not received a review any time during that year. Payments to nursing facilities for these recipients totaled approximately $165 million. A similar finding was noted in our prior audit report, which disclosed that 22% of recipients did not obtain a review. The finding on slide 10 relates to hospital claims, which disclosed that MCPA did not adequately monitor its hospital claims audit contractor and did not recover improper claims identified by the contractor. The purpose of these audits are to ensure that services provided to Medicaid recipients were necessary and not excessive. Our review disclosed that MCPA did not obtain certain deliverables required by the contract, including a plan detailing steps MCPA should take to reduce the occurrence of future improper hospital payments. And as of August 2022, MCPA had not pursued recovery of improper payments totaling $6.9 million that were reported by the contractor. The next slide discusses 3 other findings related to the processing of recipient eligibility information, validating costly ventilator claims, and audits of certain providers. Next slide, please. Findings related to information security systems and controls are redacted and will be presented in a closed session. Slide 13 contains our conclusions. We want to thank you for your time today and are happy to answer any questions.
In with Aaron Hunt.
Hope everybody has a good holiday. I was just mentioning to the vice chair that I've probably been on this audit committee longer than anybody. And I've listened to these audits from the last administration to this administration. And I keep seeing things in here. We don't have processes. And I keep wondering what the cause is. And when I listened to some of your comments about procedures and people not being billed and the underpayment, people not doing their job, I always question, did we lose everybody every time we change administrations? Does everybody quit? And our staff and everything? Because this isn't just the head of the group, the chairman, if you will. It's not their issue necessarily, is it the people underneath them? What are we doing wrong, or what can we do when we see repeat findings? What can we do in the middle of this to sit back and say, I need a report from you on all these findings we had today, and to actually get a snapshot of why these repeat findings keep continuing?
Well, I think one thing though is that most of the audit period, or the entire audit period, there was no change in administration. So yeah.
I was here,
Yeah.
I was here when we first got in and we went through the O'Malley audits, and it was the same theme. And I keep asking the same question: is why is this continuing? This isn't just me, the head of the group. This is me, the person working in those areas. What are we doing? Are we not, what's happened to that staff that's been so good? This process has been happening all along. We do these jobs every day. These people do these jobs every day. What can we do to help? As far, like you said, sit back and have a tick mark. I want a report from you on all 10 of these findings, or 8 of these findings. I want a status of where they stand today. What can we do as a committee to help with that?
Well, that was a sigh for effect. Brian, do you want to take a stab at it?
So I want to point out a couple of things. I think the specific questions about the staffing and the gaps as a result of the transition is better suited for the department. But from our perspective, 8 out of the 11 being repeats, we gave them the roadmap. The roadmap was there, and I was looking through some of the findings. Some of the things that we're talking about, they didn't address the specific instances of cases that needed following up on last audit. They had still not followed up on those this next audit. It's not a process. We gave them the instruction. The guidelines were there. They just didn't implement them. So as far as a status, because of the number of repeat findings, you're going to have a trifecta of follow-up related to this report. One would be, odds are, because of the number of repeats, it's going to be subject to JCR language. That's going to require them to submit.
My question is that we see this. You gave them the process, blah, blah, blah. We did all that. But what can we do as a committee to say, okay, I have number 4, let's say. I want you to fill me, give me an update. It's like a status report. Show me your progress on that issue. It's not like it's a detailed audit again. It's just somebody sitting down and say, finding number 3, we did address that. Here's how we're addressing it today. It's moving forward. You're saying that you give it to the department. They said, just let it go. That shouldn't be acceptable. It's because like saying it's okay not to do these.
See, and what you're talking about is not just fixing the problem, but putting a process in place to make sure that appropriate action is always done. So it's one thing telling somebody, go do this. But what you're talking about is then checking every month, every week, every day, somebody checking, have you done this job you're supposed to do? That's what you're talking about.
Yes, and accountability. And I hate to say that word in this committee, but accountability here. And this isn't, I'm not asking for this person to sit down and give you a detailed report, which is going to take somebody 20 hours to go through, just to sit back and say, where are we at on this process? Because then that gives somebody the accountability at that level to say that, you know what, we are fixing it. We are doing it. To give me a process and I don't do it, that doesn't help.
No, but the status reports that they're going to be required to submit because of the number of repeats is just that. It is the status of the implementation. And until they come up with a point where anything that's not, we follow up and they need to.
Okay, I'm asking for a status report on even the ones that are just today, the new findings, a status report such as that. Because obviously the status reports aren't working because we're getting repeat findings. So I'm asking what we can do to help prevent that. This is costing money every time we do this. We all realize that. And, we're going to have some budget issues coming up. And these things, when you start looking at the compound of every one we're doing, it becomes an issue for me personally. But I just think that there could be a way and a better way we could do it as a group to ensure we're getting results on the issues that we've asked them to address.
Well, we will be doing a formal follow-up probably within the next 6 months or so of the calendar year. And we will ask them for a formal status report for all the findings here. And then we will do a review and we report back to you. And actually that follow-up process is something the committee started years ago, that formal follow-up process.
With all due respect, it's not working.
Yeah.
So, and that's kind of what I'm trying to say. It's not working where we're at today. I think I got my point, but my point is that we really can't live with these kind of things. I mean, if you look at the waste of time, energy, manpower, and whatever, wind power, however you want to word it, it's continuing, and we don't have a real way to sit back and say, you know what, you have a job to do. Here's your job, do it. You know, last audit, we talked about somebody not being able to tell somebody when they quit. We pay people after the payroll, and we sitting down and say, we have to write a procedure for somebody to tell me that when you quit, I need to take you off payroll. Now, that should be something that's fundamentally easy and in the process, but we don't seem to have a mechanism to prevent these things from continuing. Isn't that so? How they do? Thank you.
I agree with Delegate Arntz. You know, the one thing that the committee has been trying to do is to, when there are significant findings, to call the departments and agencies back before us for more timely updates. So, for example, later during this hearing, we have the Maryland Department of Labor coming back up for an update on unemployment insurance. Because there were significant findings before that, we recognized it was important to bring them back for an update in person, not just, you know, written, so that we can ask the department questions more directly. So if that's the will of the committee, we can certainly have the department come up at a future hearing as well to provide a more timely update. My question, I guess, for Mr. Hook and his team. So I'm looking here, and it looks like there's 6 repeat findings. When was the previous audit done of MCPA? That how many years ago was that? So, you know, when we see repeat findings, we're wondering, since when was the last time that they were notified about this, and how much time did they have to remedy the prior findings?
About 3.5 years.
3.5
prior.
years.
The
Okay.
the current audit period is about a little bit over 3.5 years for this audit. So it would have been 3.5 years prior.
And just to be clear, this audit is covering the time period from when to when?
August 1st, 2018 through March 31st, 2022.
Through March 31st, 2022. Okay. All right, thank you. Senator Hester.
Thank you, Chair Lamb. I appreciate your report. I actually, you know, I've been thinking a lot about this, and I'm delighted that we have coming up the DBM Audit and Finance Compliance Unit. I mean, the legislative branch can only do so much, but shouldn't DBM be looking at this stuff in between?
I think they'll tell you they are. They do
Okay.
come to our office. They will request reviews, work papers for certain audits, and then they will then get copies of some of our work papers, and they will go out, and then they are their function is to make sure the agencies have in fact corrected the problem. So that's a very good question. That's, I think, said that before, and that unit has grown. I think there's 6 people now in that unit at DBM. It has grown.
Is that sufficient for the number of repeat findings that we have? I mean, every year we have 7 or 8 agencies which have repeat cybersecurity and PII findings. I mean, would it be wise and cost effective for us to beef up the staff in DBM to do this better?
I think a question for maybe closed session is DBM capable of following up on the cybersecurity findings? Do they have the expertise? When we have our closed session, my staff all are certified information systems auditors. They're CPAs. I do not know if DBM's unit has such people who understand those complicated issues sometimes.
And for the awareness of the committee, I think in your packet, there is a exhibit that shows all these repeat findings, and they can be broken down by department too, which range from 9% repeat findings to 100% repeat findings. Any other questions from the committee? Okay. All right, we're going to go ahead and move on. Thank you to Mr. Hook and your team. Obviously stand by. Next, we'll invite the Maryland Department of Health. We have Secretary Laura Herrera-Scott, as well as Deputy Secretary Ryan Moran, who will be coming forward. Great, you may begin.
Good morning, and thank you, Chair Lamb and Chair Solomon, and to members of the committee. For the record, I'm Laura Herrera Scott, Secretary of Health, and I want to begin by thanking the Office of Legislative Audits and their team for their work and partnership throughout the most recent audits. I want to acknowledge again, unfortunately, that the audit today does contain significant findings related to oversight and compliance in Medicaid's areas of enrollment and eligibility, Office of Long-Term Support Services, financial and fiscal operations, and cybersecurity controls. I want to begin by reiterating the gravity with which MDH leadership is addressing these findings. Though these findings are based on activities that occur prior to our leadership, it is incumbent on us to address the findings and move our department forward. Today's presentation will review the actions the department is taking to address the findings. I want to assure you that we are committed to addressing these findings and process improvements that will help us be accountable for action and improvement moving forward. To walk through the department's presentation and action steps for each audit finding, I want to introduce Deputy Secretary of Healthcare Financing and Medicaid Director, Dr. Ryan Moran.
Good. Thank you, Secretary Herrera Scott, and thank you, Chairs Lamb and Chair Solomon, and to all members of the committee for the opportunity to review this audit today. As the Secretary mentioned, again, for the record, my name is Ryan Moran, Deputy Secretary of Healthcare Financing and the state's Medicaid Director for the Maryland Department of Health. And I also want to add in my comments that both Secretary Herrera Scott and I are committed to ensuring the internal and external operations of the Medicaid program that are efficient and easily accessible to participants, providers, and other stakeholders. Before I walk through each of the audit findings, I want to highlight and provide an overview of Maryland's Medicaid program and its essential work to the state, which is followed here on the next slide. As you may know, Maryland's Medicaid program enrolls more than 1.7 million Marylanders. And it's subsequent to the agenda slide, if you can go to the next bullet points, so they're all on the same page. It includes over 700,000 Marylanders who are kids. And as has been already mentioned by OLA, the program is jointly funded by both the federal and state government. 20% of the state's population receive their healthcare coverage through Medicaid, including 5 in 8 in nursing home residents and 1 in 3 in people with disabilities in our state. I think we also would be remiss if we did not mention the historic nature of what currently Medicaid is doing in terms of the public health emergency unwinding or redeterminations that we are undertaking with both planning and preparation for this particular period covered under this audit began. For context related to that, during the public health emergency, individuals across the country, as you may know, maintained their eligibility for Medicaid. And Maryland's Medicaid program enrollment grew during that time period during COVID from 1.4 million members to 1.8 million members at the start of the unwinding period. The federal public health emergency was declared over, and with that deemed end of the federal public health emergency starting in May of 2023 and for a full month period, Maryland Medicaid is currently in the unprecedented work of reviewing eligibility for every single Medicaid participant. This administration, under Secretary Herrera Scott's leadership, has been most aggressive in a comprehensive campaign outreach and taking advantage of as many federal flexibilities that are available to us to ensure that that re-enrollment process is efficient and as easy as possible. And our goal is to, of course, to ensure that any eligible Marylander who is currently eligible for Medicaid retains their coverage. And if they are deemed ineligible, that we provide them with pathways to other sources of healthcare coverage as well. Today's audit scope, which has already been mentioned, includes the area of enrollment and eligibility, as well as the Office of Long-Term Support Services within Medicaid's offices. Both of those offices within Medicaid are key and crucial to our redetermination efforts. But audit also includes a review of our MMIS security and controls, third-party insurance recoveries and financial payments to providers, including hospitals, nursing facilities, and home and community-based services. As noted by our colleagues from OLA, this is not the sole audit for the Medicaid program. This audit covers approximately the scale of $4.3 billion in total expenditures out of the total state $14.1 billion expenditures for the Maryland Medicaid program. Accompanying this audit are three others within the Maryland program, which is Maryland Medicaid's Managed Care Program Audit, the Office of Pharmacy Services, and the Behavioral Health Services Administration Organization. For today's presentation, I want to review the enclosed 11 findings and their proposed actions in the categories related to the three areas. We bucketed them, the first being financial oversight and monitoring, the second being the Office of Long-Term Support Services, and the third being enrollment and eligibility. Beginning with financial oversight and monitoring, which is finding one, that Medicaid did not ensure that all referrals of potential third-party health insurance information were investigated and appropriately recorded in our MIS system. This is an important finding as Medicaid is, by federal law, the payer of last resort. MDH is actively working on a plan of correction with our third-party liability vendor and information technology staff to address automation of a carrier file that will interface into MMIS. Also, the vendor will ensure that we have access to the right data and the right interface to ensure that improper payments are not made in the future. In addition, in leveraging information on third-party liability from our outside vendor, we are also in the process of investigating all MCO referrals where there might be third-party insurance. That audit did have a backlog, as we have noted in terms of our discussion from 2019 to 2021. And the backlog throughout this process has been resolved through the hiring of additional staff. And the 2022 backlog was resolved in October of 2023. And again, we are working to try to automate those referral processes in the system from the vendors and our MCOs, so that's not dependent upon staff. Finding two involves ensuring MDH in terms of enrollment and eligibility category for identifying and preventing and recovering questionable Medicaid patients for incarcerated and deceased recipients. This finding obviously connects with the Office of Eligibility Services in partnership with our finance teams. As OLA rightfully mentioned, some of these findings unfortunately were connected to the disruptions of major systems that were used to control and prevent improper payments. Access to these systems were restored after the security incident in late 2021 and mid 2022, and MDH is working to ensure that we identify, prevent, and recover questionable Medicaid payments as appropriate and good stewards of taxpayer dollars. Related to improper payments for deceased individuals, with system restoration back to the security incident, we have resumed data sharing between the department and the Department of Human Services on recipient cases to ensure that there aren't improper payments. And we are also, I think it's important to note, working on system enhancements that will migrate us to a new platform in March of 2024 that will allow documentation of these reviews and investigations of questionable payments that will support documentation for future audit purposes. Some of these cases, as identified in the report, were a result of MDH needing to keep certain cases open during the pandemic that I talked about with continuous eligibility, particularly in instances where the primary household member was deceased, but other in the household that were connected to that individual could not be closed. MDH has most recently undertaken system changes as key improvements to our enrollment process to ensure that all reviews of Medicaid eligibility are now done at the individual level rather than at the household level. This change that we just implemented in November will also prevent these similar type of cases from occurring again. Further, related to the need to improve efforts to identify and prevent questionable Medicaid patients for incarcerated individuals, I want to note that MDH is undertaking efforts to improve data sharing between our office and the Department of Public Safety and Correction Services. As you may know, eligibility for incarcerated individuals is complex and shifts based on healthcare needs of that individual. As practice required by federal law, Maryland suspends Medicaid coverage for incarcerated individuals. However, if those individuals do need some type of inpatient hospitalization, then they can become eligible for Medicaid. So therefore, access to the correct and real-time data system is imperative to improve improper payments as we follow people along that healthcare coverage. While there are limitations with our current MMIS system infrastructure that was implemented in 1995, MDH is committed to working with corrections and public safety to ensure this exchange of information including the update of a dating sharing MOU. Further, we also want to note that the Department and the Corrections of Public Safety are strengthening our partnership and our work, and actually in hopes of submitting a landmark 1115 Medicaid demonstration waiver from CMS that hopefully, if approved, will allow Medicaid coverage for healthcare services and for individuals up to 90 days pre-release. So the work to support the improvement and necessity of data sharing across these agencies in the future will be particularly imperative. Slide 6, finding 3 is very similar in terms of the result of system disruptions due to the security incident. Access to the system was restored to support Medicaid eligibility and processing in our MMIS system. And we've also formulated a work group internally to update standard operating procedures to support these efforts as well. The final findings that I'll talk about are in the Office of Long-Term Support Services. Those are findings 4 through 8. They were all under the purview of Medicaid's Office of Long-Term Support Services. This is a particularly important office and component of Medicaid, which executes and oversees our home and community-based waiver services, as well as our nursing home services. This office, in terms of long-term care and community-based settings of care, was one, I'll remind you, one of the backbones of the Maryland Department of Health to be on the front lines of the COVID-19 pandemic. In partnership with the current director of that office, we have been particularly focused on ensuring that it has the resources that it needs, including the people, systems, and processes to functionally operate. We're improving, we're undertaking aggressive recruitment efforts, as well as executing on reorganization of that department to better align the work across the office for the specific divisions of responsibility. And we've made significant progress to address the basics of the office infrastructure. We have also worked in tandem to address and or begin put solutions into place for finding 5 in this area. For finding 4, we have established a process for community first choice recipients to be monitored by nurses. This is done, as OLA mentioned, in partnership with local health departments since the inception of the program that dates back to 2014. As of October of 2023, 5% of recipients had not received the nurse monitoring service. That is down significantly from 16% as highlighted back in 2019 from the auditor's report. And we will soon be executing nurse monitoring agreements with local health departments that clearly outline the responsibilities and have developed new systems and technology tools related to data management systems to better track nursing monitoring completion. The next slide and the final slide is oversight of our utilization control agent vendor, which provides review of appropriate stays and services related to Medicaid facilities. I will say that the department currently has made a huge step forward this summer to award a new contract to a utilization control agent vendor, in which more targeted measures of accountability were written in as part of that RFP that will support the department contract monitors in the future. We take our role in vendor oversight very seriously. Finding 6 is also connected with that new contract, and it will ensure that the department has a process to ensure recipient ventilator care claims submitted by nursing homes are valid. The new contract in that vendor included the scope of those audits beginning in 2024. Finding 7 is an area where there were real staffing issues and insufficient resources to conduct audits of medical daycare and support planning providers, especially during the pandemic. MDH will resume those audits and support planning and medical daycare facilities in 2024 to conduct the required annual audits that's outlined. Chair Lamb and Chair Solomon, with that, I think that we will allow any questions or comments that the committee has at this time.
Thank you. I'll begin with some questions. I want to piggyback on the line of questioning that Delegate Arntz first started earlier. Recognizing that obviously the leadership of the department has changed quite a bit with the transition of administration, but many of the folks that work within these departments or within these offices within the department remain the same. And so, I guess my question is, how will you, as the new leadership coming in, be able to make sure that the staff that are there are properly overseen and managed so that these types of incidents don't continue on? Because the leadership from before overseeing these staff are gone. And so you folks are new coming in, what reassurance and perspective can you bring to this committee as to why you can assure us that this will not go on in the future?
So I'll start and then Dr. Moran can continue. I just want to start by saying that middle layer that stays during these transition are the core of the work that we do, and they work hard day in, day out. And I will say under the prior administration, between the vacancy factor that was higher than usual, the COVID-19, the cybersecurity incident, and quite frankly, some of the automation that Dr. Moran referenced were not in place. So I don't know that it's a function of the people that do the work every day as much it was not having enough resources and or tools at their disposal to be effective in their respective roles. Since Dr. Moran has stepped in, we've added staffing, we've gotten some contracts through for automating, as well as quality oversight, including partnerships with local health departments for some of the monitoring that's going on. He can speak to the details, but I do want to just emphasize the staff that we have works tirelessly day in, day out to get this work done. And they just, unfortunately, were under-resourced across the board to be effective in their roles.
Thanks, Chair Lamb. I'm not sure I have much more to add. I mean, I agree with the secretary in terms of the look that we are taking at all divisions within the department. It really does boil down to three things when you're talking about any of these findings or any other agency oversight, and that is people, systems, and processes. So we're ensuring that people have the systems and processes. Obviously, we've already cited, and OLA cited the vacancy rates that had an impact on some of these findings that were occurred. But you've got to have the tools in place for people to efficiently do their jobs as well.
Okay, I wanted to turn to slide 4, referring to finding number 1, where there are references to the backlog that had been resolved. If you could be a little bit more specific as to what that backlog was, and how many improper payments were found, as well as potentially how much was unrecoverable or lost potentially by the state. Could you be more specific on what that backlog was?
So the backlog that existed was related to the carrier file of the OLA auditors mentioned. We have sort of two processes in terms of we use a third-party liability vendor that allows us to get information related to third-party other insurance that individuals may have. That's one stream. We also get referrals from our MCOs in terms of if there are other third-party that may be available. The backlog existed, Chair Lamb, on the MCO portion of that date backs from 2019 to 2022. That's incumbent on our staff to complete. As mentioned, we did, for that particular backlog, hire contractual staff as an interim solution, if you will, to address that backlog all the way through of 2022, and that has been resolved.
So it was a backlog in simply processing?
That's correct. Yes, and also back to the systems and automation, there wasn't an automated process in place between those files that we receive from MCO insurance referrals to put into our system. One of the improvements that we're making is to ensure that we automate that process in the future.
So with the backlog being resolved, that processing has been completed, but potentially we have not lost any funding or improperly reimbursed for anything as a result of that?
So I don't know if I can speak to the specifics on that, Chair Lamb. I'd have to do more analysis in terms of the final resolution on that, as we just completed that within the October timeframe, but happy to follow up.
Okay, yeah, if you could follow up with that information, that would be helpful. I have, I guess, one last question. You know, between, I think, slide 4 and slide 5, these are findings like 1, 2, and 3. You know, there are references here, obviously, to the cyber incident that occurred. However, it seems like much of the time period of this audit actually occurred before the cyber incident occurred. So for example, on slide 5, the references here to the security incident. And in some ways, there's some reference to the fact that because of the security incident, those who were incarcerated or deceased receive benefits that they shouldn't have. They were receiving these benefits even before the cyber incident occurred. So can you speak to why that was the case and why there were not systems in place even before the cyber incident? Because it is obviously easy to be able to point to a cyber incident that occurred, but a lot of this predates that.
Yeah, so a couple of things. One, there's a sort of number of confounding factors in terms of the timing of this particular audit. Again, as I mentioned, some of the reviews of those particular cases, the way that enrollment and eligibility was working was done at the household level. So some of those cases could not be closed because of the public health emergency. Because if we disenrolled that individual that was deceased, if you will, that would have closed the whole house. Now, one of the changes that we did make as part of strengthening our redetermination process and strengthening the enrollment and eligibility is to ensure that the state conducts that review at the individual level. Chair Lamb, there were systems and processes in place. I think to the Secretary's point of sort of oversight and monitoring of that, we're trying to improve, and I touched on those particular efforts in terms of data sharing with corrections and public safety. There's a data sharing memo that we need to update to ensure that we have that. So COVID-19, the pandemic, the security incidents, which did drive major system disruptions. I also believe that OLA cited certain time periods in terms of when they were doing those reviews which would aligned with the disruption that happened as part of the security incident as well.
So 2 just very brief follow-ups, and maybe you have to follow up with information about this that you can get to us later. Can you share how many of the missed individuals were as a result of the cyber attack versus which ones were just not addressed because of the cyber attack itself, right? How many preceded that? And then secondly, you mentioned that up until recently, folks were disenrolled based on household. And how long has that been going on? That if an individual in a household is no longer eligible, the entire household was disenrolled?
So for the first question, happy to get back with you in terms of the answer of that. Senator Lamb, on the second question in terms of the household review, Maryland, along with 29 other states, in partnership with CMS in August, identified that the issue in terms of longstanding guidance from CMS about how to conduct renewals. What we have done is in August, we took immediate action. We were one of the first states to do so, recognized by CMS to correct the system. I'm personally incredibly proud of Medicaid colleagues in our information technology systems that did Herculean efforts over the last 60 days to make those system changes accordingly. We did everything also to protect Medicaid participants in the process upon hearing about this in partnership with CMS, which included immediately pausing procedural terminations in our re-enrollment process in August. We made a commitment that we would not resume procedural terminations until those system changes were fixed. Those were fixed in November. We also, as we reported to the House and Government and Operations Committee yesterday on the status of the unwinding period, we saw an almost 20% increase in our auto enrollment rate by ensuring that we fix those systems as well.
Great, thank you. Chair Solomon?
Thank you, Senator Lamb, and thank you both for being here. I just wanted to first off piggyback off of Senator Lamb's first round of questions on finding number 1. So I think we would really appreciate. So I mean, 88% of these claims had not been reviewed, and it says again resolved. You know, in just the short window that the audit report points out, it's $103 million. Just that small window of 2022 that they mentioned. So it's probably significantly more than that. If you could get back to us whether there were any improper claims that were discovered, any savings recouped, what the actual monetary amount of those claims were that were reviewed, and whether there was anything improper found in them. I think we would really appreciate that. I had just a couple of other questions. On finding number 5, I guess I have to say I wasn't surprised to see this, and I know again, I mean, you all have been, I think the theme of this hearing and last month's hearing was you have a mess that you were left with. And we're trying to clean it up. Can you talk to me a little bit about how the vacancy rate within the agency, in your opinion? Well, first of all, where is the vacancy rate still within this office?
So I don't have it for this particular office right now. I can tell you that we've added a lot of additional contractual pins to help not only fill the back that we had for the merit pins, but even with filling of those, we needed more people to do this work. So more contractual pins were added as well. We can get back to you with the total number. I
Okay.
can tell you agency-wide, the vacancy factor is down to about 11%. And
Okay.
it was in some units of the department over 20%. I think when we took over, it was about 15%.
Yeah.
So we are actively working. The thing we're trying to also work is on retention, right? So we're hiring people, but people are choosing to leave. So we're working both sides. So it hasn't moved as much as we hoped, although if you looked at our hiring, that number has gone down. But we're now trying to manage the retention piece as well.
That would be great. Yeah, I mean, I think as it was indicated in the audit report, it was about a little bit higher than 14%, 90 people. And obviously hiring new people is great, but you know, for newly created positions, but we need to make sure that we fill the ones that are currently vacant. You know, I mean, obviously you can't do things like site visits and audits of facilities if you don't have the staff power. And I do. Oh. Yeah.
I just want to comment on that. I think part of, and Dr. Moran mentioned it, we have a lot of people doing a lot of manual processes. And we are in 2023, and we are looking at automating some of these processes. So some of the hold on the people is looking to automate these processes. These manual processes are very prone to error. And if we can remove that manual process and remove the error, we hope to improve system-wide the experience, not only for the member that we have to serve, but certainly for our workforce. So some of the pin issue is looking at our processes. We're not trying to fix the broken process we have, but are there things that we can stop doing? Are there things that we can automate? So we're looking at it end to end.
That's great. Yeah, I mean, I think honestly, you know, really comprehensive prior to the start of session, I think really a comprehensive understanding of the staffing needs of the agency. And if you have plans in place to automate, so then you can shift staff resources to places where, I mean, frankly, obviously you can't do an inspection, you can't do a site visit through automation. That has to be a human being. And then actually I will shift to a very parochial question. It's not directly related to this audit, but, and I think you may have heard from some of my colleagues in the county, we have had a situation where our nursing homes are not being inspected. The Department of Health had a longstanding MOU with our county Department of Health in Montgomery County. That was ended. We're not quite sure why. And we have discovered that actually our Commission on Aging just mentioned it to us again last week that we have nursing homes in our county that have gone uninspected now for several years. And so we just appreciate, you don't have to respond right now. If you have an answer, great, but would appreciate your commitment to continue to work with Montgomery County to fix that issue. And maybe restore the MOU.
Noted.
And then the last question that I had was on finding number 8. I know it said that you've recovered all the overpayments. Can you talk a little bit about what plans and changes from the deliverables that the contractor had given you are going to be in place to make sure that we don't have some of these repeats again on the improper claim piece?
So finding 8, Chair Solomon, is a part of the new, moving forward, a new contract that we have with a new vendor that starts in 2024. And as I mentioned, for some of the finding 6 and finding 7, finding 8 were tied together, more accountability in terms of oversight that the contract monitors at the department were written into that RFP. But again, about around March of 2024 is when the new vendor or the vendor that's assuming that work will begin its work.
And then, so that's great, because it sounds like maybe the previous contractor was not great. So one of the findings said that we did not get certain deliverables. Is that on the fault of the contractor, or was that on the fault of the Department of Health? And again, you weren't here, so I don't know if you can answer that question, but
Yeah, I want to say it's on the fault of the contractor, in terms of receiving that information that the department needs.
is there any liability of the previous contractor if they didn't meet their contract, giving something back, owing the department or the state anything?
So part of our work too is also ensuring that we have appropriate vendor and oversight management in place. And as well as moving forward with all of the contracts that we oversee, Chair.
So maybe Madam Secretary, are we going back to that contractor to try to recoup anything if they didn't meet their deliverables?
So we can go back and look. I don't have an answer for you today.
Okay.
Some of it also may be the way we wrote the RFP and what we asked for in the RFP. So to be fair to the contractor, even if it was something we didn't get, it may not have been part of their statement of work. So I would
Okay.
need to go back and look.
Great. All right. Thank you very much. And I will turn to Delegate Aaron's.
Thank you, Mr. Vice Chair. Just Dr. Moran, great job on what you explained. It seems like you really have a grasp on what's going wrong and what has gone wrong and where you're moving forward to. Secretary Scott, when you look at this whole process of hiring, I think Maryland has what's our unemployment rate? 1.7%? I think it's somewhere down. Is it
1.6?
1.6. Okay, 1.6%. You're not going to go out and hire people tomorrow, the next day or whatever. Are you, and these relationships you have with these contractors, is that where you're going to focus to kind of hone in on getting some of these issues resolved and accountability on that side?
So, I'm taking a little bit of a different approach. I think under the previous leadership, contractors in some cases were used as a substitute for our core workforce. We're using contractors to fill gaps in expertise that we don't have, even if we fill all the positions. So I'm not trying to use a contractor to replace the workforce that we have, but to augment the workforce we have, going back to the tools and resources that people need to be effective.
Kind of like to fill the vacancies in a sense, but if you can get it done outside, that's the best way to achieve it.
No, not to fill the vacancies. We're working to fill the vacancies, but to fill such as an auditing function, someone to go behind. We don't have that workforce built in to clean up some of the stuff that we want to make sure we're doing right. So having oversight by a third party is helping to ensure that these mistakes don't happen again. They may not be never events, but we certainly don't want to have 6 repeat findings in the future.
Okay, last question. And again, I appreciate what you said, Dr. Moran. Would it be difficult, going back to my last set of questions for the auditors, would it be difficult to do a blurb on some of these findings to say our status? I don't want to tie up time. I think, time is something you don't have enough of as it is. But when we're looking at these findings and look at these things, even the cyber side of it, to give us a status report, I mean, I don't know, every monthly report on something of the findings that were out there this time, so we keep at least track of the findings that we're hitting this audit period as opposed to next. Would that
Well,
be?
we can certainly work with our audit team, Mr. Fred Delgett, who's in the room for some of these audits. His team does follow along and holds us accountable internally to meet the requirements, especially for those that are repeat findings. So we can work with Fred and his team to get you something.
I know that you're overwhelmed, and I get that, and I don't mean to put more out there. It's very difficult to see things like this as you're moving forward. But thank you very much for the presentation.
Delegate Harrison.
Thank you.
One thing, if you could clarify something that you said, on slide, regarding finding 2. Did I hear you say correctly that the software that's being used currently, was put in place in 1995?
So that's related to our MMMIS system, very key system in terms of information. And the answer is yes.
Okay.
No, say what MMIS is,
Oh,
so she knows.
Medicaid Management Information System.
All right, but it was still 1995,
With its implementation, yes.
long before cloud computing and everything else. Okay, and so where are you with getting something that's more current? I think that goes back to what Delegate Solomon was talking about, and what you were talking about, a lot of manual processes. Is I would assume that if you're 1995 software, there's a lot of manual processing that goes along with that.
So a key part of our work, and this goes back to updating of information technology work of that is partnering closely with our Chief Information Officer of the department. We have what we call Medicaid transformation roadmap in terms of IT systems that we have also been working on since we come into the department, delegate on updating and taking a look at what are the appropriate and realistic timeframes in terms of development of RFP, putting out the RFP, and then implementation of that work. This one, the MMIS system is the basic framework and foundation too of a Medicaid program in states. It's a big lift. It is on our roadmap, not in any time soon because we haven't gone out for an RFP for that, but it is on our roadmap for us to consider as part of that transformation exercise.
Okay. I appreciate that, but I think that this goes back to, I guess, a number of the repeat findings because we're so far behind and things are not getting done. So you said that it's on the roadmap. Can you give us a time frame or an approximate time frame?
So again, it's I think approximate time frame is you probably have 2 or 3 years out, if you will. I'd have to go back and check the current dates. We're also in the process of updating that because it hasn't been looked at in some time, or at least under this administration, to ensure that those are characterized appropriately.
Okay. And do you think that it would be that it's not too far-fetched to think that other states may have a more modern system? Because we all have to report back to the federal government.
They do, yes, yes. Or they're older in some senses. But some states have, in terms of their roadmap implemented. And so Clint and in partnership with other state colleagues are in contact to see what our lessons learned or what they are also putting into place in terms of their vendor experiences too.
And just to add to that, when we took over, we did not have a chief information officer, and Clinton Hackett, who's sitting behind me. Clinton, if you can raise your hand. He has joined the department, comes to us by way of Wisconsin. And so he is helping to look at all our systems, including the MMIS system and the roadmaps that predated us.
Okay. The other thing that I wanted to just ask about, so Audit has said that they've made several suggestions over the years for standard operating procedures. And I know that you have taken some time to work towards some updates based on what we have here. Where are we and where are you with those standard operating procedures so that we don't continue to have these repeat findings? And what is the time frame? What can we expect from you to implement these suggestions?
So full disclosure, I haven't seen the roadmap that OLA had suggested that was presented during the prior administration for the repeat findings. So we welcome looking at those and comparing them to the roadmap that we have given ourselves to see how they align or don't. I mean, we'll take guidance from wherever we can on improving the processes that we have. So I have not seen those.
Okay, do you plan to look for them to get them?
Yes.
Okay. And what can we expect time frame? I'm trying to, I guess, be a little bit more specific because this has been going on for a long time, and I'm recognizing that you're just getting there and you're starting afresh, so to speak. But I think that we all want some tangible deliverables from you, just like you want.
Well, I can't give you a timeline on when it would done. I mean, again, we have put in processes in place. We're bringing in contractors to help with this work. And as Delegate Ahrens requested, we can put together the findings and what actions we're taking towards those findings, but I can't give you a timeline right now.
Okay, can you give us a timeline of when you may be able to come back with those actions?
Well, we've given a lot of actions already, and some of the issues are resolved. So you have some of that already, but we can certainly through this process give you updates as we go.
Okay, thanks.
Chair,
And thank you, Secretary Scott, for being here today to answer questions. And I do appreciate how rapidly you jumped in and tackled some of these issues, try to get the department back on track. So my question is, over some of the previous meetings, we've heard where people have been with the department a long time and they've learned their job over a long period of time. So when they leave or they're not there, no one else knows how to step up and do that job. Now, I'm sure automation will help with some of that, but do you have a plan or intend to implement a plan for training? So we have a well-trained workforce.
So yes, on the training, but more importantly, codifying that institutional knowledge that goes with the people when they go. So we are actively developing SOPs so that knowledge no longer just sits with one person, but is a documentation of the function of the job. I think we were here before you last month over the budget issue, which was a function of one person leaving, and that we can't have a single point of failure. So we are putting SOPs in place for core functions that today revolve around people that have been with the department for a long time to make sure procedurally it's documented and there's a desktop. So if someone were to come behind them, they know what needs to happen with that work.
I'm sure we're all glad to hear that. So thank you.
Senator Hester.
Mr. Chair, and thank you guys for being here today and for all the work that you've done on Medicaid, especially this year, expanding it hopefully to our public school systems beyond where it already was at. My question is about the roadmap. So I heard roadmap mentioned a couple times. First of all, the roadmap for the OLA findings, but then also about updating the software and the systems. And so could you clarify, is there a roadmap to update the software and the systems?
So with Clint now and his leadership, we are actively working with information technology to update that roadmap under this administration, yes.
So when do you think that roadmap will be complete?
So I don't know if it's ever complete. It's sort of a static document of planning, procurement. It has certain different deliverables in that. But we're hoping to have an opportunity of a view of what this would solidify and work like in terms of priorities in those timeframes, the top of 2024.
That would be great. Could I request a meeting to look at that with the CIO?
Sure.
Okay, and then what are the barriers to the automation? Will those be solved in this roadmap?
Yes, that's the goal.
Okay.
And the barriers, I don't know, they just weren't done. And so we have some low hanging fruit that we're going after right now to automate processes.
Okay, thank you.
Senator Benson.
I thank you all for your presentation. I'm just sitting here trying to get my arms around what I see as the problem here with this, with the findings and this whole process. Talk to me just a little bit about the training for the contractual workers, I mean, for the people who come in for contractual. Could you talk to me a little bit about that?
Well, it's the training for contractual workers starts with standard operating procedures, which is why it's important to have those in place, and would be done by the division manager or division lead of that particular unit, directing those employees, just like merit employees, if you will, to complete that work, whatever that task might be.
What's the turnover? Is there a huge turnover rate in your division? Do they come? Do they stay? I'm particularly concerned about the contractual workers. Do they stay, or are they there for a period of time?
Well, the contractual workers are usually short-term workers. They're on 6-month or 12-month contracts, depending on what they've been brought in to do. So I don't know what the turnover is. It would depend on the contract that they were on, and I'll have to get back to you on the turnover for the merit employees.
That's the other question I wanted to ask. The turnover of the merit employees.
I don't have that number. We'd have to get back to you on that. The tenure of the staff is pretty significant. But we.
Say
can-
that again.
The tenure, the years worked at the department is pretty significant. So there's a lot of institutional knowledge in Medicaid, but we could get you the turnover rate in Medicaid. I just don't have it today.
Thank you.
Waiting for your microphone. I'll just use my teacher voice. I just wanted to say thank you on the 1115 waiver. I know a group of us were at the NCSL conference earlier this summer with the Biden administration's drug policy head, and there was a lot of conversation around that and what it'll do potentially for the opioid epidemic and folks in our system. So I wanted to highlight that, Dr. Moran, that you mentioned how important it is to get these systems right as we expand Medicaid coverage to those in our population that really need it the most.
One last point to bring up here, and then we're going to go into closed session. It struck me that in OLA's slides on page 8, it says that the local health department or the Baltimore City Health Department was responsible for 821 of 901 one-year overdue recipients. These are reviews of the quality of personal assistance services being provided to residents in Baltimore City. It's like 90% of all the monitoring visits that were over 1 year old are coming from Baltimore City and the Baltimore City Health Department. What's the follow-up plan with them? Because it seems like that's significant.
So it's working individually with Baltimore City and other local health departments. I also talked about a nurse monitoring agreement that the state and the Office of Long-Term Support Services would enter with local health departments, including Baltimore City, to spell out scope of responsibilities and deliverables in that work. So it's partnering with them, Chair Lamb.
Okay, so you're going to follow up with that because it's like 90% is coming out of one jurisdiction. Okay. Senator Hedelman.
Quick, wanted to echo what Chair Solomon said too. My county, I know, is very interested in that waiver. We are spending $2 million plus of opioid restitution money on MAT, and it would be a huge assistance to have some federal money going to that too. Thanks.
All right, thank you. I'm going to move request that we move into closed session. So those folks who are not part of OLA or the department to please step out of the room. I'm going to move to have the committee move into closed session. I'll need a second for that.
Second.
All right, so this meeting will be closed. Any objections? No. This meeting will be closed under General Provisions Article 3-301 to discuss cybersecurity information if the body determines that the public discussion would constitute a risk to security assessments or deployments related to information resources technology, network security information, or deployments or implementation of security personnel, critical infrastructure, or security devices. Once we move out of closed session, the folks that are being asked to step out can step back in. In the meantime, we will ask Mr. Hook and his team from the Office of Legislative Audits to come back up to the witness table.